viewers and subscribers. This is DAROGA video number 28. OSCE part 2, more pearls of wisdom. Last week we did a mock OSCE in my hospital with 15 year 5 students, and I picked up a few things which I would like to share with you so you will benefit from it during your end of the year exams. The overview of today's video introduction. I will analyze the example OSCE in detail, and first of course we ask ourselves what information is available in the corridor, what should you do, what are the expectations when you're inside the room interacting with the volunteer patient and being observed by the examiner, what are the key learning points, and I will give you a summary in a flowchart, and last but not least, Jimmy, our Zen Master-in-Chief, will make a few comments. The station we used last week had the following information in the corridor. Jan Smith is a 25-year-old primary gravida attending her routine antenatal visit at 31 weeks of gestation. One of the midwives measured Jan's fundal height at 27 centimeters, and she has asked for you to review her. Take a focus history from this patient, ask any relevant examination findings via the examiner, consult Jan on your working diagnosis and how you would further manage her. Below is her customized growth chart. Here you see the customized growth chart which was available in the corridor. Now it's crucial that you try to process the information, and my recommendation is read the information once more and ask yourself maybe what is your first thought, what is going on here. And then look once more at the growth chart, what is given. We are dealing with a para 0, her height and weight, a normal BMI, and here we see the fundal height which was plotted before when she was 28.5 weeks. Today when we see her she's 31 weeks. So the plot of 27 centimeters has not been completed yet. This was a point where students went a little bit off the rails because they didn't understand. They thought that this was the plot of the current visit. That was not the case. So important to take that information on board. Okay, I would like to suggest you now to write down what was going through your mind before we proceed. What was going through your mind when you read the information I just presented to you? I think I would encourage you to repeat the information, the key information in your mind. And the key information is, we are dealing with Jan, a 25-year-old. This is her first pregnancy. She's 31 weeks and the fundal height is 27 centimeters. So do realize we are in an obstetric station. And then in obstetric station, it's always to consider the mother and the fetus when you take a history, when you examine, and when you come up with a management plan. So, as I discussed before, it takes two to tango. You can hear the Zen Master-in-Chief now in the background. That's wonderful. So, what would you expect? I would like you to apply common sense. The vast majority of OSCE stations are not made, they're not a banana on the floor to make you slip. It's trying to check important clinical presentations. So, what is clear from the information? That there is a concern, the midwife has a concern about the fundal height. That's why she wants you to review the patient. Okay, so where would the plot, the 31-week plot and the 27 centimeters be on the chart? And this was information that was missed by some lovely students who are a little bit nervous. And that means very difficult to recover from that oversight. Here is the plot. And immediately it springs to mind that the slope, the actual slope, is less than the expected one. So immediately, intuitively, you realize, oh, this is a small for gestational age or an IGR station. Light bulb moment. Fundamental height less than expected. So SGA IGR is most likely what the university or the examiner wants to find out more about. So, essential that you process this information before you enter the room. Okay, with this information now I would like you to pause for another moment and write down for yourself on a piece of paper what tasks are expected of you inside the room. How would you go about the first two tasks required to come up with a provisional diagnosis? Sometimes a metaphor helps. I like to think about a waiter. Imagine you are a waiter and you ask yourself, how many courses do I have to serve and what is the content of the different courses? I found this lovely picture because this is a picture where waiters or waiters-to-be get instructions how to earn more tips as a waiter or waitress. So here, what is the meal? The first course is take a focus history regarding SEIGR from Jan. That's what actually the task. The second course would be examine Jan via the examiner. So any examination findings you ask from the examiner. Then thirdly, share your provisional diagnosis based on 1 and 2 and then suggest management to Jan. Do realize we are dealing with a provisional diagnosis based on your history and examination only. So it's maybe not a certain diagnosis yet. It's not yet a definitive diagnosis. Okay, so the tasks are take a focus history regarding SGA from Jan, examine Jan via the examiner, and then your diagnosis, your provisional diagnosis, and your management. So pretty straightforward. This is the structure which I would strongly recommend you, wholeheartedly would recommend you to follow. Okay, now you enter the room. Start with quickly introducing yourself. My name is such and such. I'm the RMO here. And summarize the information which you have picked up in the corridor and which you have, which your brain came up with, as we discussed before. When you summarize that information, the patient, Mrs. Smith, can tell you whether you're on the right track or not. And that's very helpful. Hello, Mrs. Smith. My name is such and such. I'm one of the RMOs here. I've been asked by the midwife to assess the current situation. I understand that this is your 25 years of age and this is your first pregnancy and that you are 31 weeks. So I would never say how old are you and how far is the pregnancy along, because that information is given and that information on the information sheet is correct, full stop. The midwife has asked to see me regarding the fundal height. Is that what you understood as well? So check, am I on the right track or did I misread or misinterpret it because the information because I'm a little bit nervous? If yes, if she confirms, wow, you're on the right path and you're going to nail this station. So now the question is, did you consider asking specific questions about any risk factor in her general medical or surgical history for SGA-IGR, any of those risk factors in her family history, any, she doesn't have previous history because it's her first pregnancy, so we would expect that you would ask a few questions about those risk factors. By the way, it's always good to check that there is no doubt about her dates, because otherwise the total approach might be different. But that's not the case. She is certain about her dates. Then you could ask her a few questions about her current pregnancy. Were there any complications? Can you tell me about the routine bloods we do at booking, blood and urine? What about the first trimester screening for Down syndrome and trisomy 18? What about the morphology scan? What about the glucose tolerance test? Those are the routine screening programs we offer to women in Australia, and it's good to quickly ask her. Then when you examine, it was great if you would realize, could she have preeclampsia? Because preeclampsia and SGA-IGR is a well-known combination. Then, of course, it's reasonable that you remeasure the fundal height to make sure there was no error made by the midwife. Okay, now let's look at what was on Jan's information sheet. So information she would volunteer to share with you if you would ask for it. And compare what your thoughts were and what Jane's background information was. Here's her patient profile, 25 years of age. She's a student engineering and in a stable relationship with Simon. So nothing remarkable here. First pregnancy, rhesus blood group is O rhesus positive. She's 31 weeks, no doubt about her gestational age. Her height and weight are normal range, and she is from Southeast Asian origin. Jan was very reliable patient lady. She attended all her antenatal visits. All her antenatal screens were unremarkable. So, bloods, urine, and euploidy screening all normal. Morphology scan, normal anatomy, no gross malformations, and the biometry, the fetus size was on the 40th percentile. So at that stage, no SGA. And she had a normal glucose tolerance test, so nothing, no hint of gestational diabetes. So the sky is boringly blue. That's what you need to take on board. Of course, as I discussed, we are dealing with an obstetric station. It's reasonable to expect that you would have asked fetal movement felt. Then some students asked as well whether she had abdominal pain, pervaginal discharge or bleeding. Did she feel feverish, fluish? Had she normal bowel and bladder function? Maybe asking for a febrile illness or a viral infection, which could be pointing at an early growth restriction. I thought that was wonderful. Then quick questions about medical surgical history, no allergies or medications apart from a multivitamin, no significant family history. And then the only positive point was she had a history of 20-pack year smoking history, and currently she cut down a little bit, 15 cigarettes a day. So this is low-hanging fruit. It is reasonable that you would address that with her and explore whether Jan is interested in cutting down further, because cigarette smoking affects the baby's birth weight in a negative way, as we all know. She doesn't drink alcohol and doesn't use illicit drugs, because illicit drugs go together with growth restriction. Then examination, always start with the vitals. Here, important to check for the blood pressure explicitly. Does she have signs here of preeclampsia? Examination, abdomen examination, nothing remarkable. You check the fundal height and confirm it was 27 centimeters indeed. You could check quickly for the fetal lie and presentation, longitudinal and cephalic, and of course it's reasonable again to expect that you will listen to the fetal heart rate. Remember, pregnancy, it takes two to tango. The heart rate was 140 beats per minute and in principle reassuring. So now we have the information from the history and examination. By the way, the presentation does not warrant to do a speculum or bimanual digital vaginal examination. If the student would ask that, the examiner would indicate that the patient would decline that to prevent you from losing precious time. Okay, so this was the information on Jan's information sheet. Now let's go to the examiner, my perspective. I allow you now to look behind the scenes. Okay, my assessment form had 4 headings. 1, the student, it's reasonable to expect that the student will be able to demonstrate that he or she is able to take an appropriate history. So, first dot point, checking for risk factors For IUGR, there's a little typo there, or SGA. So for instance, pre-existing hypertension, diabetes, renal disease, smoking. It is reasonable for us to expect from you that you would check explicitly whether she felt the baby is moving still normally. Quick check for the due date, is there no error in the calculation? Checking for the first semester screening results for trisomy 21 and 18, and reasonable to check the morphology scan. Was the baby not too small at that stage? Were there gross congenital malformations? So we would expect that the students would address a few of these dot points. Sounds fair enough. Then the next piece of information was the physical examination. We would expect from a student to check the vitals with a focus on the blood pressure. Remeasure the fundal height to exclude a measurement error or an inter-observer variation, and request a fetal heart rate to confirm that the baby is still alive. Okay, the third course would be the provisional diagnosis, and the fourth is, we would expect the student to explain using simple basic English that there is a suspicion that the baby might be small. But important that it's just a suspicion here. There is not yet a diagnosis. The fundal height trend is no more than a warning sign, or it's the surveillance, and look a bit further. It would be not appropriate to scare the patient here at this stage already with growth restriction, early induction, or even a cesarean section, as sometimes happened. That would really, I have no choice then to mark you down for that. And of course, it's reason to expect that you would explore interest in quitting smoking. Then, regarding the management, well, what we would expect the students to ask for is an ultrasound scan fetal growth. Even better if the student would make explicit that it's about the biometry, the umbilical artery Doppler, and the amniotic fluid index. It would be reasonable as well, but not mandatory, to check for a CTG to have more accurate information about the fetal well-being. But that was not mandatory in this station. Okay, so then another part of the assessment form, communication skills. So I would observe your body language. Do you make eye contact? Do you try to have a friendly, non-threatening facial expression? What is the language you use? You should avoid using medical, doctor speak, jargon. Are you able to build a rapport with the patient? I asked that from the volunteer. Did you feel comfortable with this doctor to be? And did you show that you respond to patients' verbal and non-verbal cues? Yeah, if the patient shrugs her shoulders or starts frowning, I would like to see that you pick that up. And then time management wise, it's ideal. You don't want to come across as rushed. And on the other hand, you don't want to feel or to notice too often that you're hesitant, or you say, okay, all right. If you say, okay, all right, 5 times, that comes across to me as that you're a little bit lost. And the general competence for that, for me, it's very simple. If a student would follow the structure, take a focus history, yes, followed by dedicated examination via the examiner. 3, discuss briefly what the most likely diagnosis is, SGA, without scaring the patient, and then request for an ultrasound scan of fetal growth. That would be all to pass this station. Okay, so the good candidates use the 4 pillars of success. You can see here a beautiful sculpture, a part of the Parthenon on the Acropolis in Athens, where the 4 women, the caryatides I think they're called, support the temple. So keep that in mind. Those 4 women support the structure of the temple already for more than 2,000 years. And if you had to identify the 4 pillars, you would do the same. It's also the good candidates, they express themselves succinctly. They don't waffle, they don't go around in circles. And usually they, every now and then they take a little break, 2 or 3 seconds to reflect. and that's fantastic, rather than waffling on. And the good students, they are able to build a rapport naturally. So if you're a caring person, you don't have to play, you are who you present who you are. And the good candidates usually finish right on time. Okay. Last but not least, the good students did not get bogged down in details. So you request an ultrasound scan fetal growth, you might mention quickly what it entails, and you would ask whether the patient, whether Jan would like to have more information without giving all the details, because that was not requested. If you ask a question from Jan, would you like to have more information? She will tell you yes, so then you would know that there is more points to be gained. Hey, great diplomatic question. So let me summarize now in a flowchart. In the corridor, read the information carefully 2 times. Ask yourself, what is at stake here? What am I dealing with? Where am I? Am I in a country setting? Am I an RMO? Am I in a GP? Am I part of the Royal Flying Doctors? Then secondly, take a history, a focused history of Jan. When you read the information, you realize there's something not right with the growth of the baby. Take a history about growth. Then the next step would be that you examine Jan, but focused. You focus on the fundal height, the blood pressure. That's all. And the fetal heart rate. And the third step, resulting from 1 and 2, it confirms what you picked up in the corridor. We're dealing with what could be an SGA baby. So you tell her, without scaring her, well, the fundal height is a little bit less than expected, the increase. So that's why I would like to request an ultrasound scan. And the ultrasound scan is, in this example, the diagnostic test. The ultrasound scan will tell us whether the fundal height was right or wrong. That is all required. If you know this, if you look with the famous retrospectoscope, it's pretty straightforward. And of course, there is time pressure, and you're unable, like this chap, to do something of the clock. The clock is ticking relentless. This concludes our OSCE Part 2, more pearls of wisdom, but don't close down. I have still 2 important messages for you. First, it's clear that the life of our lovely Zen Master-in-Chief is not always fun either. Here he is at the groomers and Jimmy dislikes when his nails are cut. So he looks away and is sometimes growling. By the way, today, as we speak, I'm very overwhelmed by the fact that we have now more than 14,000 views on DAROGA and 122 subscribers. So really, I feel humbled. This is wonderful, and that motivates me to continue. And last but not least, this is how Jimmy looks like after, after his OSCE exam, after he went to the groomers. He's a happy chappy. Thank you for your attention, and I trust this will be somewhat helpful. All the best, Alphonse Rooks.